A very good afternoon, all of you. Today, the topic of my lecture would be biomechanics of the edentulous state. When we talk of biomechanics of the edentulous states, we are basically combining the biology of the edentulous ridge and the mechanics or the mechanical influence of the prosthesis. Biomechanics can be defined as the relation between biological behavior of oral tissues and physical influence of the dental restoration. Correct? Like I said, the biology of the oral tissue, or that is the residual ridge mainly, and the physical influence or the mechanics or the physics of the dental restoration. Compromise in the integrity of the masticatory system, which is very obvious. Adverse functional and cosmetic sequel, you have to keep in mind. Artificial dentures are replacement for the lost natural teeth and their associated investing structures. The interaction of masticatory system components affected when the patient becomes partially or completely edentulous. If we make a pyramid out of this, we can always divide it into three main criteria of the function and parafunction, the morphologic face height and TMJ, and individual adaptive response. The edentulous state will be a state when there will be support from the periodontium. That is, when the teeth are present, there is full support from the periodontium. The partially edentulous state is when there is depleted support from the periodontium with or without the support of the mucoperiosteum and the residual ridge. And the completely edentulous state is again when there is entire support from the residual alveolar ridge only. The tooth support, which we consider when we talk of the biomechanics of an edentulous patient, the two principal functions of the periodontium is the support and the sensory apparatus to resist the forces exerted by the prosthesis. This is mainly provided by the periodontium. The patients needing CD therapy is deprived of the periodontal support and therefore altered functional lower transmission to the supporting tissues. In healthy dentition, teeth are not in occlusion except during chewing, deglutition, and parafunction. Total time teeth subjected to forces of mastication and deglutition in a day is approximately 17.5 minutes. The total time and range of forces are found to be well within the tolerance level of the periodontal tissue. The complete denture support. The complete denture support is mainly achieved by the mucosa support. That is the area of the mucosa available. But this is, as we all know, is limited. What? Computed mean denture bearing area in an edentulous maxilla as 22.96 centimeters square and in mandible as 12.25 centimeters square. So therefore, the total area of the periodontal membrane of the natural teeth in each jaw is 45 centimeters square, which is like 338 times more than that of an edentulous mandible. That is, the total area of support by a edentulous state is much more than that in an edentulous state due to the periodontal membrane. The denture bearing area becomes progressively smaller as residual ridges resolve and the mucosa exhibits little tolerance to the denture bearing. Tolerance can further be reduced by any metabolic disturbances also. So the total support when we have the teeth, then when we have complete set of teeth, the total support is always the maximum. Then if we switch on to a partially edentulous state, the total support is reduced. And finally, the total support by the mucosa to an edentulous state will be minimal. If we talk about the masticatory load, the natural teeth exhibits around 44 pounds of weight, masticatory load, whereas a complete denture only exhibits 13 to 16 pounds of masticatory load. So according to the study by Carlson, bite forces appear to be 5 to 6 times less in CD wearer than a person with natural teeth. Forces largely depend on the type of food chewed also. Normally, a prosthetic patient usually sticks their diet to selecting food that requires less effort in the mastication. When we talk of the residual ridge, the portion of the alveolar bone and its soft tissue covering that remains after removal of the teeth is your residual ridge, as defined by GPD 8. Residual ridge is a multifactorial area. The biomechanical disease which results from the combination of anatomic, metabolic, and mechanical determinants. RRR, that is residual ridge, the remaining residual ridge is directly proportional to the force factors. Now, traditional design of the dentures include many features, and major goals is to reduce amount of force to the ridge and thus the residual ridge resorption. I like to correct myself when I said RRR in this slide means your residual ridge resorption. Okay, not the remaining residual ridge. So residual ridge resorption is a multifactorial phenomenon. This I have already taught you before. And also residual ridge resorption is directly proportional to the forces applied. So this is very clear to all of you. And I'll not go into the detail of residual ridge resorption and the factors which affect residual ridge resorption. Okay. Now, traditional design of the denture, which includes will include many features and major goals to reduce the amount of forces to the ridge and therefore will reduce the residual ridge resorption. These prosthetic factors will include. So, what are the factors that are used or involved in the denture, complete denture, so that the residual ridge resorption is reduced? These factors will be broad area coverage. These factors you already know. I've taught this topic, residual ridge resorption before. So if the broader the area, more will be the forces dissipated onto the mucosa, and therefore the ridge resorption will be reduced. There is decrease of number of dental units. That is, less will be the masticatory forces onto the ridge. Increase with the width of the buccolingual width of the teeth. This factor is not one of the major factors, but if you reduce the buccolingual width of the teeth, the artificial teeth, then you are majorly reducing the amount of forces acting. Improved tooth form, avoidance of inclined planes. If there are inclined planes in the denture, then the offset forces on the denture will increase. And therefore, this point is related to the next point, which is the centralization of occlusal contacts. Provision of adequate tongue room, which is very obvious. If there is not adequate area for the tongue, then the stability of the denture will be compromised largely. Adequate interocclusal distance during the rest of jaw relation. That is, the vertical dimension at rest should be adequate. If it is not adequate, or let me put it this way, if VDO or VDR is increased, right? That is, VDO is increased, what will happen? Residual ridge resorption will increase. Functional and parafunctional consideration would mainly include your occlusion. Now, healthy dentition teeth are in occlusion during chewing and swallowing and parafunction. Primary components of the human dental occlusion are your neuromuscular system, the craniofacial structures, and the dentition. This is, you all know. The dentition develops is series of characteristic by a period of dental, alveolar, and craniofacial adaptability, which is the time motor skills and neuromuscular learning develops. The complete dentures are designed that their occlusal surfaces permit both functional and parafunctional movement of the mandible. Orofacial and tongue muscles also play a major role in the retention stability of the complete denture attained, and this is attained by arranging the teeth in the neutral zone. So these are the functional and parafunctional considerations. The development and adaptation of the occlusion can be explained with the help of this chart diagram, which says that the developing dentition has what? Extensive sensory input, development of motor skills, dental-alveolar and craniofacial adaptation. Then we get what is known as the healthy adult dentition, in which the dental adaptation, where an extrusion is there, learned protective reflexes develop, and the bone adaptation also develops. Then we come to a deteriorating dental dentition, which has partial edentulism, decrease in the dental reflex adaptation, and periodontal diseases and pathology, which is associated with bone loss. And lastly, we come to the edentulous state, where there is residual ridge resorption and increase in the parafunctional movements. Now, mastication and swallowing also play a very important role when we talk of the biomechanics of the complete denture. According to studies done by Shepard, mandibular movement patterns indicate similarity between patients wearing complete denture and patients with natural teeth. Swoop and Creed, he suggested that the frequency and duration of tooth contact while swallowing has significant effect on the deformation of prosthesis. Swallowing has more contribution for transferring energy to the denture base, to the underlying mucosa than mastication. That is very obvious because we do more of swallowing movement throughout the day than we eat food. Studies have shown that swallowing generates forces that are little higher than the chewing forces. Marked difference in the functional content in patients wearing complete denture and with natural teeth are seen in this aspect. The mucosa mechanism of support is very important. Movement of the denture during mastication is important. Progressive changes in the maxillary and mandibular relation and eventually migration of denture does take place. Different physical stimuli to necessary motor system becomes important. When we talk of the parafunction, repeated or sustained occlusion can be harmful. Bruxism, frequent cause of mucosal soreness plus additional loading. Wearing new dentures, initial discomfort, unusual pattern in the surrounding musculature can be seen. Sore tongue is thrusting of the tongue against the denture can take place. Occluding new dentures strengthens your confidence. Parafunctional habits, if present in the patient, will add loading on the denture bearing tissues. So mastication and parafunctions can be studied in terms of the direction, duration, and magnitude of forces. When we talk of mastication, the forces are mainly directed vertically. But parafunctions, the forces can be offset, that is, can be horizontal as well, and therefore are more harmful. The duration and magnitude of forces also during mastication is, these forces are intermittent, okay? Intermittent in magnitude and duration, and there are light durations, okay? But when parafunction is talked about, the duration and magnitude forces is prolonged and extensive during the diurnal and nocturnal time. The stress distribution to denture supporting tissue, the force of long duration, major role in prosthetic failure can occur. Mucosal health promotion, hygiene and therapeutic measures and tissue conditioning is very important. Force stress decreases by the extension of base within morphologic and functional limits. Resilient denture base lining materials and reduction in the area of occlusal table becomes important to reduce the force and stresses. If we talk of the viscoelastic characteristics of the denture supporting tissue, that is the bouncing effect of the residual ridge mucosa, there is initial displacement which causes delayed elastic deformation, thereafter instantaneous elastic recovery, and continued and delayed elastic recovery. Histologically loaded epithelium shows decrease in epithelial ridge, obliteration of connective tissue papilla. Human soft tissues take at least 4 hours for recovery after load. Has been an established factor. Change in tissue displaceability functions of age takes place. Longer period of recovery of disclosed mucosa is seen in elderly people. The pressure which is forced onto the human soft tissue, that is the oral mucosa, is 0.13 gram per Newton meter, which is 95% of its resting thickness. Function and parafunction generate pressure. This causes tissue damage by occluding local circulation. The pressure can also cause correct clinical techniques. Permanent resilient liners can be used to reduce this pressure, but force and time can still be controlled by nocturnal tissue rest, which is partial. So what are the various resilient lining materials that can be used for healing of the oral tissue? These can be your tissue conditioners and obtundant materials. Changes in the morphology becomes very significant correlation between morphology and function, parafunction in edentulous patient. Atresion and abrasion of teeth, premature reduction in facial height, more conspicuous in edentulous and CD wearer. This is the pictorial depiction. As you can see, how the oral and orofacial musculature shows extensive changes in a dentate and an edentulous patient. Talgreen gave some findings about marked mandibular base and bent and small gonial angle, about the strong vessator and temporalis activity in dentulous patients. If these are so, then there will be marked resorption. And patients with strong muscle activities can stabilize denture by biting hard and longer. And this can also cause muscle soreness. Centric relation, therefore, becomes very important when we record the patient's jaw relation so that we can get an accurate maxillary and mandibular relation, that is an accurate VDO, vertical dimension and occlusion, and vertical dimension and rest, and thereby we can control the residual ridge resorption. TMJ changes can also occur if there is certain amount of pathology associated with the your oral structures and with the occlusion. What are the behavioral and adaptive responses when we come to talk about the complete denture and residual ridge resorption? The cosmetic changes, the dental treatment can take care of the functional and cosmetic reasons. Communication with the patient, cosmetic expectation, and careful explanation is very important. The changes associated with edentulous state are usually the deepening of the nasolabial groove, the loss of labiodental angle, the decrease in the horizontal labial angle, the narrowing of the lips, the increase in columella philtrum angle, and there is prognatic appearance which is marked. The adaptive responses, which has to be incorporated or explained carefully to the patients, are the acceptance and uses of complete denture by patient. And this is very complex. It requires learning and muscular skill and motivation to the patient. Learning can be by acquisition of new activity and change in existing ones. And muscular skills can be developed by the patient by gradually over the period of time. Memory trace becomes important and integral part of habituation. Difficulty in storage accompanied with age accounting for difficulties in oral patients getting used to the denture. The stimuli is identical, specific to achieve adjustment. Denture wearing skill requires skilled performances. Certain aspect of learning and coordination decreases with age. We all know that. Stimulus doesn't elicit strong response, repetition results in decreased responses. Now, what are the psychological responses in a denture wearer patient? These can be understand the patient's motivation to seeking the prosthesis carefully to identify the problems beforehand. Emotional factor also play a significant role in the etiology of the dental problem. Most significant emotional problem associated with aging is depression. Early recognition of these factors become important, and then you can refer the patient to a psychiatric evaluation also. Kenneth and Barbara reported that when CD population examined for depression were the depression inventory, most of the depressive symptoms are found to coincide with age, which included denture wearers. So in conclusion, when we study the biomechanics of edentulous state, we have to study the entire biology, including the oral tissue, associated structures, the changes in the oral tissue over time and with aging, the changes in the residual ridge resorption phenomena. You also need to know about the psychology, emotional stability of the patient when giving a complete denture to such a patient. And this therefore will be included in the biomechanics as a whole. The success of the prosthetic treatment is predicted not only on the manual dexterity, but also on the ability of the dentist to relate to patients and to understand their needs. For a denture to carry out its function well, it should have good retention, stability, and support. These are the obvious requirements. But the dentist should also have a good knowledge of the denture environment and biomechanical factors in order to provide the best chances of success of the prosthetic treatment as well as the treatment of the patient.